By the people, for the people, the gathering to get healthcare now. Chapter 5. Prudence and reality. Right view, that is, seeing healthcare as it really is, gives prudence to the gathering so that the members' actions are appropriate to real situations. Schumacher said, this clear-eyed objectivity, however, cannot be achieved, and prudence cannot be perfected except by an attitude of silent contemplation of reality, during which the egocentric interests of man are at least temporarily silenced. Prudence implies a transformation of the knowledge of truth into decisions corresponding to reality. Everywhere people ask, what can I actually do? The answer is as simple as it is disconcerting. We can each of us work to put our own inner house in order. The guidance we need for this work cannot be found in science or technology, the value of which utterly depends on the ends they serve, but it can still be found in the traditional wisdom of mankind. The healthcare financing systems in the United States do not enable people and patients to choose what they want, when they want it, and from whom they get the advice, care, and treatment. These systems do not follow nature in having multiple pathways for communication and protection. They were not born of the step-by-step building of a living system, but out of convenience for the U.S. economy that was under stress of depression followed by war. Development was built on the premise that adults had enough information and education to make intelligent decisions about the values of the products and services they chose. Further, the products and services were deemed to be affordable and readily available. But the measure of that was the profit of the enterprise and not the health outcomes of the patients. The consideration that these systems were about the preservation of life, the complex interconnections between people, their labor, and their dedication to each other was set aside in favor of monetary exchange. The consequence has been poor economy, poor health, unnecessary loss of life. While other nations have given health problems more attention in the last 5 generations for reasons of economy, they have done only slightly better in health outcomes. The main problem is about how to live and not about how to trade representations of goods and services for healthcare advice and treatment. Top-down management simply has not worked. Regardless of the outcry about high cost and bad outcomes in healthcare from the most knowledgeable people in our society, a top-down solution to the problems has not worked. The solution, if there's to be one, may come from the bottom up, from the patients, their interconnections with each other, and the inclusion of knowledgeable caregivers in guild-driven, self-directed small communities. People will need to be nudged into organizations that raise their level of understanding of medicine and leave them empowered to act in their best interest and economy. Healthcare providers are the most likely class of people in this kind of community to have a positive impact. However, these providers will be a subset of physicians and other non-physician providers, those who deal with both health and disease, acute and functional disorders, and have a strong desire to teach medicine and health maintenance to people in a comprehensive and reproducible way. Life-sustaining systems arise from direct participation. The organization of guilds and communities into life-sustaining networks begins with the providers of care and not with other agencies, regardless of how well-informed or well-meaning these agencies may be. Enrolling patients into Medicare, Medicaid, or private insurance plans does not solve healthcare delivery and cost problems. Good health is about understanding health and healthcare problems and their solutions within a community of other people who share knowledge and concerns, some of whom are expert advisors and caregivers. Paying for all this is a commitment made by each individual drawing on the resources they have available from their labor, their entitlements, and the gift circles to which they belong. In the words of Abraham Lincoln, labor is prior to and independent of capital. However, the main barrier is that labor is hard to organize. In most other industrialized nations, the organizational structures necessary are imposed by law, and the elite classes of administrators and medical care providers tend to have less opportunity for financial gain. But the general population suffers less expense and seems to have a slightly better health outcome. However, this top-down approach has not created a medical knowledge base that would allow the patient population to win against the relentless march of chronic illnesses that make people old before their times. We seem to be wholly dependent on radical changes in the environment to get at the causes of our problems not addressed by acute care medicine. The interconnections characteristic of living ecological systems in which harmful elements are excluded and healthy nutrients created and supplied are not in the current medical financial systems. In the case of the current systems, knowledge is not power, but simply a fire alarm to which people have become accustomed to ignoring. Bottom-up organizational structure imitates nature and creates trust. And it's time to take a step back and put into place, through mutual help, what is wanted and needed as people and patients. The paradox is the organizers and caregivers are patients too, and can be properly empathetic if empowered by their patients acting in concert. The nudge to physicians to act as a team and to embrace the solutions to both good health care and cost control has been given through several programs from the government and the private sector. The programs presume that the people and patients are already organized into plans of insurance through which physicians must just become accountable by proper financial incentives, positive and negative. The financial incentives that are positive seem only to manifest about 20% of the time, and only partially for the healthcare providers and not at all for the patients. However, the nudge has made a window where there was a wall, and the possibility that the wall will fall as healthcare providers bring their patients through it. This is the paradigm shift that was needed. Prohibitions against voluntary associations and mutual support seem to be few, but there are barriers to overcome in shifting trusteeship, a needed service within a cooperative, shifting it to new platforms.